Hi everyone. Thanks for coming along. Welcome to the seminar series extended edition as part of the Festival of Digital Health. Extended edition because this is a sort of an ongoing thing we've been doing for the university, the seminar series for the last few months, and we'll while this is the last one, I think, for this year, we'll start again in September with lots more sort of bi-weekly seminars around digital health. We've got speakers today. First will be Lawrie Kidd, and he will be talking about making digital health solutions work in clinical practice where they're needed. And then we have Claire, who will be showing off the Dragons of Afterland board game, and she'll be also running a workshop where you can try it out after the talk as well. That's the schedule for today. There'll be a time for Q&A after each section, and we'll have a break in the middle for some networking and coffee and things like that. So a bit of housekeeping. So no fire drill expected. And so if it does go off, it's a real thing. And the assembly point is just across the road outside Senate House. The webinar will be recorded, which I should probably start recording, or if someone else could start recording, it is recording. And it will be made available online afterwards. For anyone online, if you could stay muted during the presentation, that would be great. There will be extra time for Q&A at the end, and you can either use the Q&A functionality in the chat or just raise your hand in the Teams to ask it. And we'll also be taking some photos, as Miguel is doing, throughout the afternoon for Leap. So if you don't want to be included in any of these, please let us know. So without further ado, I will introduce Lawrie, who is our first speaker. And I'll be talking about, as I said, making digital health solutions work where they're needed most. So just a bit about Lawrie to introduce him. So he's a consultant anaesthetist living in Bristol and working at Gloucestershire. And he works with the research and innovation team in the trust as a clinical lead in the innovation taskforce, as well as championing a culture of transparency and openness as a freedom to speak up guardian. And he's the clinical product lead at the hybrid digital health provider DrDoctor, which works across the UK and handles over half of the UK outpatient activity. Without further ado, welcome, Lawrie.
Do I have to stand in front of you? No picture of me. I don't have any slides.
Walk around.
Cheers, Matt, for the intro. So I thought I'd start by talking about the kind of conflicts of interest, because I've got loads actually, and that's kind of why I'm here. And I think it's important to be kind of transparent about these things. So my kind of day job is as a consultant up in Gloucestershire. And then I do other stuff as well. So I work for like the MPS Foundation, I work for Xyla on occasion for an insourcing company, and I do some advisory work for them. And I work with Health Innovation Networks, and I work for the trust with the innovation group and the research for Gloucestershire, and do loads of different things. And I suppose the conflicts that I have are important to be transparent about, but also I think it gives me a kind of perspective, because I kind of sit on both sides of the fence, and hopefully it'll be useful. My story started probably about 4 or 5 years ago when I've got 2 little girls. One is born on the 31st of August, so as young for the year as you can get. And we thought we'd try and get ready for school. So we put her into nursery to preschool. She should learn, I don't know, where her elbow was opposed to her hand, and other important preschool life lessons. And so suddenly my kind of daddy daycare day, which is on a Monday, suddenly was empty. And so I had this time, and I'm not very good when I get bored. So I started looking around, and I found there were loads of kind of semi-relevant jobs out there, which are interesting. And I found one which I applied for and got, which was working for a research body, which was really empowering and really rewarding. And I use the word rewarding with caution, because actually by the time I told my medical indemnity company, which is like the kind of medical insurance company that I have to pay insurance to be a doctor, I told them I was doing this. They increased my premium, so it almost completely wiped out any kind of financial gain from doing this job. But I found it really rewarding. And at the same time, I'd been a consultant for a couple of years, and I was looking around kind of the staff room and the coffee room and looking at a lot of my colleagues, and a lot of them were behaving like they were trapped and behaving like they didn't have much agency. And I think healthcare is an amazing space, but it's also an incredibly tough space, and I think it grinds people down, and it's incredibly, it's incredibly disheartening at times. And what I thought was actually doing this other stuff I found quite energizing. And I don't want to sound too smug, but actually, I absolutely love my clinical job. And my whole reason for looking at doing other stuff was to keep my clinical role sustainable. And there's an irony to that, because actually I'm way closer to burning out now than I ever have been before. But that's a kind of separate talk. And one of the jobs I absolutely love is Freedom to Speak Up Guardian, which is kind of like a whistleblower supporting role that I have in the trust. And one of the cool things about that job is I get to meet all the new medical students who join the trust. And what I get to say to them is, congratulations on starting on a really exciting career. And I genuinely believe that. Okay, so I think healthcare is amazing. The NHS is amazing. It's really tough. But I think, and there's loads of stuff wrong with it, but there's so much stuff that is right about it. And it's really important to kind of remember that and be part and remember this as you're kind of going on this journey. But then I started doing other stuff, and those kind of complex and different roles I have kind of enabled me to sit on both sides of the fence. I kind of see both the kind of push from industry, but also the pull from the kind of patient-facing side of stuff. And when I think about this, I thought about what's Bristol famous for? And you've got like Banksy, you've got the bridge. I think of analogies, weird analogies. Turns out Darth Vader is Bristol based, and some Ribena was also discovered in Bristol. Chocolate bars, and also hot air balloons, right? Which apparently were 12th on the list. So I'm going to go with the weird analogy of a hot air balloon, right? So in order to get a hot air balloon and to travel somewhere, you need to have something that actually works. And if we all sat down and got a piece of paper and said, look, come up with an idea for a hot air balloon, you'd all probably be able to design something. The fact is, actually, like, the idea is the easy bit. And my role at DrDoctor is kind of through a product lens. Those that you kind of don't really know what product means, you've got kind of commercial people who sell stuff. Then you've got product people who kind of build the stuff and kind of get it into the market. And then you've got the kind of delivery team who then get stuff being used. And then you've got the kind of success team who then optimize the usage and try and really embed it into the process. So that's kind of how it works. And so I used to work in the kind of transformation side of the business, so kind of trying to unlock those relationships and dealing with implementation, stuff like that. And I wanted to kind of get upstream and make sure the stuff that we were building was right and was going to work. So actually, in terms of this hot air balloon and kind of in order to get it airborne, what do you need? And so it comes back to the design. I think designers in health tech are actually the superheroes. We were talking earlier about the kind of human computer interface, and like interfaces, I think, is where it's all about. I don't know if any of you kind of work in any kind of patient facing role, but I have, hand on heart, never used a piece of software or a piece of technology that if I had a 14-day guarantee, money back guarantee, I wouldn't return within those 14 days. I've absolutely never used a piece of tech which I think is user focused and is remotely fit for purpose. It is clunky, is awkward. You need to do online training because it's so counterintuitive. It's abysmal. And I think actually kind of there's so many kind of layers of complexity to healthcare products that I think actually the user bit is really important. Is often forgotten. So I think and to use the hot air balloon analogy, it's like, you're taking someone up who's got a wicker allergy, who's scared of heights, and so you give them a wicker basket which is open-sided. Like, that's basically kind of like what most healthcare products are like. So I think it's I think you need a good product as the first thing, and then you need to think about the kind of product market fit. So how is that product going to work with the market and the people who are using it? And in kind of product land, they talked about the MVP, which is the minimum viable product. And this is about the kind of how bare bones can you be that people want to use it, and you can start learning and iterating and improving and understanding better what to use. And it's a real fine balance, actually, because it needs to be bare bones, but not too bare bones. It needs to work. It needs to be functional, but you need to then be able to listen and learn and get the signal from the users. So one person shouting loudly that they want this particular feature might actually be a stroke of genius, but actually 10 people saying they want a feature might be a slightly stronger signal that you should listen to. So it is kind of interpreting that. And then you're looking to scale, and then you're looking to profit. And I think profit, lots of people think is a bit of a dirty word in healthcare because actually, you know, like we don't do that because it's the NHS and it's wonderful. DrDoctor recently laid off like a reasonable number of software engineers and people and colleagues. Some of that was strategic in terms of kind of different alignment and new products. But one of the things that's really important is that actually, if what you're building doesn't make money, then you can't pay the wages, which sounds really grubby, but that's the reality of how it works. And I wouldn't say it's kind of Machiavellian, but I definitely feel my opinion has changed a little bit since working in a more competitive industry where people lose their jobs. And Matt and I were talking about that NHR funding and stuff. It is competitive out there, and I think you need to kind of maintain that competitive advantage. I think it's really important. But it's not just the kind of the return on investment for the company, but it's also for the trust as well. So how are you, if they're spending money and it's real money, and sometimes these things are expensive, how are you going to actually demonstrate the benefit and the return on investment that they are spending on this? Because people don't want a zero-sum game, and it's really difficult. And in terms of that kind of product market fit, what's also really cool is the speed of change. And you know, you don't need to look very far to see the kind of power of AI and what can be done. One of the reasons I haven't got slides was it's too easy to make really good slide decks using AI now. So I pretty much try and avoid using slides. And vibe coding, I don't know if any of you know what that is. A few nods. That's essentially being able to code anything, products, platforms, technology, with no code whatsoever. So you can basically drag and drop. You can just write a description. I want a green box floating in the middle of the screen, which says click here to consent. And I want underneath this the following information. And it just does it. And it's absolutely amazing. And I know someone who built a health tracking app that integrated with Apple Health and Samsung Health that was, you know, scalable and worked really well. And it took them 20 minutes. So it's completely game changing. And what that's doing is actually democratizing access to these solutions, which is really cool. So you need a product. You need a product that works. And then you need to sell that and work out how to sell stuff. And I think broadly speaking, there's two approaches. You can either go from the top down, say from the kind of C-suite down, or you can go from the bottom up and try and get your kind of grassroots champions. And the problem with that is that actually you kind of disenfranchise the other end. And there's also a massive tier in the middle who are always left out. And if you go back to hot air balloon, you've got tethers. Okay, before it takes off, like, you know, you've got all these like ropes and all these like stakes in the ground. And all these people, all these stakeholders can be potentially extra pegs and extra tethers, and they might not have the power to release the rope, but they can certainly slow it down. Okay, and that's really difficult. There's also the idea of kind of the authority, and there's something known as the scheme of delegation. Has anyone heard of that? So this is a really interesting thing, which actually all trusts and probably all big organizations have, which is the idea that if you have a matron, so a band 7 or 8 in the hospital, they've probably got a kind of disposable budget allowance of maybe £5,000 to £10,000 that they can use to spend on kind of what they want. They need to justify it, but that's about how much. That's kind of how much purchasing power they've got. They might have a huge budget on their remit, but in terms of their kind of like what they can choose to spend it on, it's very little. If you kind of go up the kind of ladder, maybe senior manager is about 25,000 probably. It varies from organisation to organisation. An executive director, a specialty director, maybe a couple 100,000. So as you kind of go up the chain of command, you've got different amounts of money that are disposable. And someone said, like, actually, if you've got an executive director, they've got the power to execute powerful decisions. That's what it means. But they're not necessarily the kind of champions who you need to instigate the change. And so you need to kind of think about who's going to be able to afford to implement the stuff. And I'll talk about pilots later. But actually, if you target at a certain level and you go for a very narrow pilot, well, that person might be able to afford it as a pilot. But what about those wider conversations? That person's not going to be the person who do it. And it's all about narratives, I think. And it's all about individualized narratives for the people you're speaking to kind of essentially lift the pegs, lift the stakes so that you can undo the tethers. So once you kind of got the idea of like who you're selling to, you've got to kind of think about how to sell. And this is like procurement. And NHS procurement is an absolute triumph of overly transparent bureaucracy and process. I mean, it's absolutely amazing. And it has to be transparent, but is bonkers. And whether it's capital funding, different allowances, like different thresholds it's met, it's incredibly complex. It's incredibly difficult. And it really is unbelievably bureaucratic and complicated. And it's kind of like undoing a cat's cradle. So it needs to be done in a certain way, and if you don't do it right, then it'll fall apart. And if you don't do it right, then you could be held to account and you could be taken to court and have to restart the whole procurement process again. So it's really, really difficult. Added to that is you've got around about 145 acute trusts, and I used to know how many ICBs there were, but actually no one knows what an ICB is now, do they? Because thanks, Wes. But each individual ICB will have its own different tender and its own different bid process and its own different procurement process. And people used to use Future NHS to kind of get the kind of procurement tenders for, let's say a video solution for our patients. And so people would copy and paste that and then put their own little spin on it. Now people use ChatGPT or Copilot to do that. But it's basically the same, but you can't just take something straight off ChatGPT. So you need to kind of amend it slightly so it's got your signature on it. So each one is different, and that's bonkers for essentially the same product. And then you've got kind of local priorities. So I work in Gloucestershire, and for some reason, we have placed care plans really high up in our kind of digital strategy. Implementing these costs money. There is zero return on investment on that. So the providers for the care plans, for example, are going to be held to account about how these are implemented and whether it was value for money on something which is inherently not going to provide value for money. So it's navigating that. It's really difficult. And then you've got the implementation stuff. So I mentioned about pilots, and luckily Pilot U, the person who drives the hot air balloon is pilot, so we're staying on theme. If you are going to train a pilot, would you want them to fly as much as they could, or just once or twice? Because it's the same resource to train someone. All the heavy lifting, all the regulatory approval, all the sign-offs, all the legals, all the DPIAs and DPAs, all the DCB documentation, all the stuff. It's all exactly the same. All the integration work is exactly the same. So whether you're doing it in a wide scale or small scale, and so I think it's really important to kind of qualify that a lot of pilots are used as a go-to-market strategy for a lot of companies, and that makes sense in terms of upselling, start small, demonstrate proof of concept, and then roll out. But what often happens is a pilot is funded for, let's say, £10,000. We're going to do this in one specialty, and we're going to go for it. If you go back to the schema delegation, that can be authorised very easily. And then if you say to someone, right, we now want to roll this out from one specialty to 40 specialties across the whole trust, and this is going to cost you, pick a number, 200 grand. How is that person going to be able to authorise that? No, of course they're not. And that money hasn't been allocated because it needs to be allocated in year to fund that work. So you end up with essentially, they call it churn. So you do these pilots and then kind of nothing comes of them. So what that does is it wastes resources on the trust side, and people become slightly disenfranchised with the process because just another pilot. And also for the provider, money is essentially wasted running these pilots. And what that does is it pushes up the prices because that's how much it costs. Because if let's say only 20% of pilots are successful, then you've wasted 8 out of 10 pilots, and that's cost that you have to absorb. So it's kind of, I'm quite opposed to them. I think you need to think about scale change from the off. I think it needs to be kind of thought about in terms of this kind of whole product market fit. I think it's really important. And you've also got red lights. So driving here today, I drove, I live down the road. I'm working this afternoon in Gloucester, so sorry. I hit a couple of red lights and I stopped. I have to stop. And that happens with implementation as well. So the trust not too far from Bristol, a friend of mine works there, and he said, look, why haven't we gone live with this DrDoctor questionnaire? I thought it was going to be amazing. So, I don't know. So I did some digging. It turned out it'd been sitting on someone's desk for almost 3 months, waiting for them to kind of sign off on. So nothing had happened for 3 months. Now, if let's say that contract was 18 months, that's 3 months of the 18 months where the return on investment isn't going to be happening, where money's being wasted. So it's really, really frustrating when you see that, and it happens all the time. And it's like old-fashioned Christmas lights, where like they're where one bulb goes and the whole thing goes off. That's what happens in a lot of the cases. And so you have some teams who are incredibly proactive, incredibly ambitious, some who are really competitive. And I'm a naturally competitive person. I love it when teams are competitive. They want to know what the response rate for questionnaires was like at neighbouring trust. They want to do better. What's NBT's DNA rate? Well, at UHVW, let's try and beat NBT. It's really, I think it's really powerful and it's really compelling. But it's incredibly messy. And there are so many stakeholders, there are so many committees. And like you were saying earlier, each one of those committees and stakeholders can slow things down potentially. Have you guys heard of Amy Edmondson? Yeah, see if you know. I've got a massive kind of like professional crush on her. So she's a Harvard lecturer who does a lot of work about psychological safety. And she's a brilliant speaker, and her books are brilliant. And she talks a lot about being safe to fail and how to make it safe to fail. I think if you speak to people who are in the kind of the reality of, the NHS is that's incredibly budget constrained, is that there's no space to fail and it's on them, and people worry about their job and their role and their patients. And, and if it comes back to me, you hear that all the time. And this kind of blame culture is really, really pervasive. So sometimes things don't go well. Sometimes things don't go right. They don't work as intended. But people are so worried about being personally scrutinized rather than looking at the system and the systems learning. That is really divisive, and it slows stuff down. And the risk appetite, I think, is really challenging, because you only need to look at the waiting list to see how badly served a lot of the population are. But people are often so fixated on their remit that they won't approve stuff. They won't kind of authorize stuff because they're worried about the patients in front of them, not the hundreds of patients who are waiting to be seen. And I think it's incredibly difficult to make people look at the big picture and not just a small picture of kind of their particular service line. But there's loads of stuff actually which is reasons to be positive. So again, taking off in your hot air balloon, you want to look at the weather, right? And the weather is a climate of austerity that we're coming off the back of. It's a climate of immense need, which is genuinely sad. It's both positive and negative, but actually there's a lot of people who have been waiting a long time for medical care that they need, and that's genuinely heartbreaking sometimes. But there is this need, there is this appetite, and the 10-year plan that's coming out soon, sometime soon. People are talking about the analog to digital shift. I think it's not just sound bites. I think it's genuinely is building, and there is this appetite from centrally and from above. There was a recent NIHR funding call which was unlimited, which is insane. It was limited, but apparently it was unlimited, and it was to do with how can you solve the elective backlog by partnering with industry. And so I was involved in loads of bids, both from a Gloucestershire side, but also from a DrDoctor side. And it was amazing to see both it's the push and the pull. What are the solutions that are out there that industry has? And people want solutions. People are looking for solutions. And the breadth of solutions that are available is really cool. And actually, when you see those align, that's fantastic. It's like the Channel Tunnel, okay, where you kind of meet in the middle. It's really, really cool. And that's something which I think is very exciting. And I found seeing some of the proposals and kind of talking through them and seeing what's available and already, could be instigated off the shelf was very, very exciting. I do loads of jobs. I pay loads of tax, and just like everyone here, I don't want to see my money wasted. And so one thing I really like is the fact that there is a laser focus on the financials. I think there's too much focus on in-year savings, and cash flow savings is like the kind of buzzword. And let's face it, if they're cash flow savings, they're easy to make. They've been made already. I think the danger is, and you see this with the ICBs, there's a lot of ICBs who run a very, very lean ship and who don't have a very high headcount. If they're told to cut the headcount by 30%, well, if you're already doing a good job, that's really hard. And that's one of the things that we're seeing at the moment. So I think actually in-year cash flow savings is the kind of death knell of long-term strategic transformation, and that's why I think it's about kind of powerful kind of strategic partnerships. And then you've also got the safety component as well, because one of my roles is as a clinical safety officer. So any software that gets used in healthcare, and it doesn't need to be a medical device, any software needs to undergo some kind of workshopping and kind of process of assurance to make sure that if something happens to it, if it breaks, what's the impact of on the patient, and how can that be mitigated? So I do that from a provider perspective, but anything that gets used then that conversation needs to be happened within the trust, and there's a kind of essentially a transfer of responsibility. So I'll say, look, if the patients don't get their text message reminder, as a trust, you need to work out how to mitigate that. And they say, okay, fine, we'll think about that. If the patient doesn't have a mobile phone, how are we going to make sure that's safe? So there's those kind of conversations. But that used to be an afterthought, and that's a prerequisite now. So you can't even get through the doors without that being thought about. And that's really powerful, because this stuff does need to work. It does need to be robust. And there's a lot of challenge in terms of the regulatory landscape. Wes Treating talking about ambient AI voice technology and ambient scribes. He said he thinks it's great. The MRHA are trying to regulate this, furiously trying to catch up. NHS England the other day said, basically, if providers, and this is directed predominantly towards GPs, are using AI scribes, then the liability if something goes wrong sits solely with the GPs. So the GPs have to do a huge amount of work on their end to use the stuff which actually kind of makes sense, kind of makes your life easier, is pretty good. It's not without fault, but neither is a spell checker, right? So if a spell checker autocorrects something, and instead of writing apostrophe, it writes catastrophe, and you don't pick it up, then you look like a mug. But because it's patient facing, there's another layer of kind of severity. So it's kind of managing that, and I think it's that regulatory landscape is challenging. But there's loads of stuff which is working. So NHS app, who's got the NHS app? Yeah, 51 million patients in May. 51 million logins to the NHS app in May, which is incredible, actually, if you think about it. One of the things I think which is really interesting about why it works, people are surprised why it works. I think the reason why it works is because it's delivered by industry. It's not delivered by the NHS app team. It's not run by the NHS app. The plan is for the NHS app team to build their own infrastructure behind the NHS app. So it'll be quite interesting to see what happens then. But actually, companies like DrDoctor do the kind of the hard work, and I generally think that's why it works, is because it's industry delivered, rather than being kind of weird, horrible, bureaucratic mess. Attend Anywhere. So Attend Anywhere is a kind of video interface that was rolled out in COVID. It was rolled out nationally. It was procured nationally. People thought video consultations wouldn't work. They don't work for everything. They absolutely don't. But these things can be scaled, and was amazing. And I always think it's really cool and really interesting conversations about data. So 80% of the UK population have got a Tesco club card. Okay, and people are okay with that, because actually, if I'm doing my online shop and I don't buy bananas, and I usually buy bananas, it reminds me that you might want bananas. Annoyingly, it doesn't say you've got 14 packs of tofu and 3 bottles of gin, and you probably shouldn't be buying this. But that's because it's geared towards supporting Tesco's, not necessarily me. Well, actually, if rather than Tesco's, it was the providers, it was the trusts, it was the ICBs, and you're looking to support them and think about how to use patients' data and how to use that interface to support the trust, but also the patient, make sure I don't forget bananas, but also make sure that I engage with healthcare properly. That's really compelling, and that's a really compelling narrative. But there's loads of stuff. So I think there's loads of opportunities, but making stuff that sticks is incredibly difficult. And I think one of the biggest challenges is you're opening the status quo. The status quo is easy, because even though it doesn't work, and even though patients suffer, the actual effort to maintain the status quo is loads easier, isn't it? There's no integrations, there's no resource, there's no digital team, there's no untethering of all these stakes so that the hot air balloon can take off. You just keep the hot air balloon on the ground, and you just carry on doing things the way you do. So it needs to be significantly better. And you've got all these levers that you can pull for change. And some of these levers are depressingly complete nonsense. So staff, okay? People talk about staff being the number one commodity. Unless a organization has got a very, very determined approach to improving the culture and improving the staff experience, staff retention, staff experience, staff culture is not a very good lever, depressingly. Okay, it's something I believe really passionately, and I'm really feel strongly about organizational development and transparency, but it's not a very powerful one. And that's despite the fact that I've sat with teams and they've cried when I've been workshopping, talking pathway mapping solutions and what we can do stuff, and they've been telling me about the moral injury that they've had because they've had to turn off things like flare lines because they're just being swamped. And the answer phone is just maxes out at 100 messages, and so just turn it off. and they know the patients are getting a bum deal, but it's really hard. But they still carry on going to work and having a rubbish time and not being necessarily that effective or efficient. So it's really difficult. Clinical outcomes. So Matt and I were talking about how you evaluate things, and clinical outcomes are really difficult to measure. How do you ascribe the benefits for a tool? It's also really slow. So the cycle of research is, like, I'm guessing a few people here are actively involved in research. It's incredibly slow from getting the money for the grant to then running the study. Don't even mention ethics. Then the actual kind of collecting the data, processing the data, writing it up. 5.5 rejections later, then you start doing the revisions, and then 3-4 years has happened. That's an immense amount of time, and by which time, 3 or 4 years, actually, like, some of these startups, some of these companies have gone bust in that time. So how do you demonstrate that quickly? It's really difficult. And then you've also got the kind of implementation gap, which is really, I think, a really interesting thing. So cervical cancer, in excess of 99% of that is caused by the HPV virus, and there is a vaccine that prevents that stops that from happening. And despite the fact there is a cancer vaccine, the uptake is around about between 60 and 70%, which is really not that high. If you look at aspirin, which is cheap as chips and is for the vast majority of people incredibly safe after a heart attack, long term, about 70 to 80% of people carry on taking something which is life-saving, life-prolonging. Same with beta blockers, same with checklists on intensive care, same with prehab, same with rehab. There are literally countless examples of things which are proven to work that aren't rolled out. And I think that's a real challenge as well, in terms of just because it's not new and shiny doesn't mean it doesn't work. And there's also the idea of patient safety as well. So somebody said to me, I think this is really sad, that one patient death isn't enough. You need a few. And I think that's incredibly sad, but I think that's probably just a reflection of the state of healthcare. So these are all levers that you think would work, but they probably don't. Instead, I think you need to define success, and you need to be really clear about what success is, what the metrics are. I think it needs to be agreed. They need to be mutually agreed. So DrDoctor, for example, we have a cost value that we make for our assumptions for an outpatient appointment. If a trust disagrees with that, well, we need to work with them. So we have an agreed metric so that when we're working out what the return is, whether it's worked or not, it's good. And it needs to be relevant to the different people. And it's all about the narrative. So if I'm a chief financial officer, all I really care about is the numbers. Does the business case add up? Okay, that's really all I care about. It's someone else's problem to deal with the kind of digital resource required or the integration or whether it actually works and the patient safety side of stuff. If I'm working in ops, then I care about visibility, I care about data. Have I got reporting metrics I can report up and report down? I need to see what's going on. If I'm sitting in clinic with someone, I don't want another job. I don't want another system that I have to log into. I don't want to have something because the admin headcount reduction, just another step that I have to do at the end of my clinic, and as well as checking my letters and doing my dictations and outcoming all the patients and doing something else as well. And I also want something that's going to impact that patient in front of me, not just, and I will care about the wider population, but it also has to be very applicable to that one person sitting in front of me. And I think that's something which a lot of people overlook. And we haven't even talked about the patient perspective as well, which is really important and shouldn't be forgotten. So I think it's about having a good product. You need a hot air balloon that can actually fly. It needs to be sold right, and it needs to be implemented well. And I think generally, the ideas is the easy bit. I think innovation itself is actually pretty easy, but people talk about product market fit. I think it's actually about product market implementation fit. And I think implementation is the most important thing, because actually adoption and scaling is really difficult. And I think that's where most health tech companies come up. And it's all about the narratives, and it's about narratives which make sense to different people. And it's about thinking about which ones and which levers people want to listen to. And there's a kind of guru in the product world called Marty Kagan, and he talks about you need to fall in love with the problem, not the solution, and not be wedded to the solution that you've built. You need to really kind of invest your time and effort and emotions in the problem and really understand that and be prepared to get it wrong. And I think that's absolutely true. And I think healthcare is full of problems, and I actually think that's an opportunity. And what I think is really cool is I think there's loads of solutions. There's loads of really impactful solutions out there at the moment. And I think that's really exciting. That's it.
Thanks very much, Lawrie. Do you have any questions in the room or online? If you do, if you're online and you have questions, please leave them in the chat. Does anyone in the room have questions? Yeah.
So, as you think about, I'm trying to go on with your balloon analogy, and in terms of not leaving people behind, I'm imagining that little ground support vehicle that's the van that's trundling along.
Yeah.
So, in my view, we need to think about digital. While we push forward the digital, we don't want to leave behind the people who can't use the digital.
Yep.
And how do you approach that? So your van isn't like 2 days behind, but is the path the other people are going alongside it's being transformed at the same time with the same whole service thinking?
Yeah.
What view on that?
100%. That is such a good point, and that's a conversation which happens all the time, and it's really important to have, because if someone doesn't have a mobile, so let's look it through the DrDoctor lens. Okay, we do provide hybrid healthcare. Okay, so we send digital letters to your phone that you can view on the portal, on your phone, or on the NHS app. What happens if you don't have a phone? Okay, what happens if you've dropped your phone down the toilet? What happens if you've run out of credit? What happens if you don't have a smartphone? You need to think about these things. And that's why the implementation is so key. So spending time with the teams and going, right, actually, what would that look like? What would that flow of information look like? So for the example of digital letters, if someone doesn't read a letter after a couple of days, then you back up to a print option. So you give a patient's opportunity to read it. And then you need to have, for all those patients who, either think it's spam or think it's a phishing scam, or who don't have a phone, they still need to get that letter, because otherwise they won't see the letter from clinic, or they won't know when their appointment is. So that's really important. I think people underestimate how digitally empowered like the whole population is. Now, there's some people totally get this who can't. Like my mum thinks lol means lots of love, puts that at the end of a text message, right? So I wouldn't trust her to necessarily book or reschedule a hospital appointment herself. She might be happier phoning up the call centre and the booking team. But we've just rolled out essentially rescheduling, where patients can say that appointment doesn't suit me, but instead I want to go for kind of next Thursday at 2:30 instead of at 10 a.m. The first person to do that in Imperial was a 75-year-old. Okay. And if you look at the kind of response rates for digital questionnaires, and if I had my laptop or had slides, I could have shown you this, but actually the response rate is pretty consistent until you hit people in their 80s. Now, people in their 80s need healthcare, and it's really important not to do the digitally less enabled a disservice. And I think it's really, like, what you can do is you can say, for example, waiting list. I've got loads of hobby horses, right? This is a really important one. If you've got a bunch of 10 people who are waiting for an operation, and you're fit and well, and you've got a phone, you do your questionnaire online, you get signed off by the anaesthetic team, you can have your operation, you're put in a kind of green for go box. You might get your operation before the person who's more complicated and who doesn't do it online and doesn't do it digitally, just because it's a bit more complicated and it takes more time to sort stuff out. That shouldn't be the case. It should be done on need, not on accessibility. And so it's working really hard. And it's that kind of like that kind of synergy of a proper relationship rather than a kind of transactional relationship where we're saying, like, this is the tool, use it. And yeah, it's very easy for people to get left behind. And it's really important that you think about everyone. I'll probably stop there. But yeah, great point.
Great, thank you. I have a question online from Michelle, who says, I find it difficult sometimes to identify the actual problem we're trying to solve, as the experience and understanding of the problem is different for each person, even within small teams. Have you experienced this, and how did you manage it without losing anyone along the way?
Wow. Yeah, it's a good question, isn't it? I think I was going to talk a little bit about ICBs and systems thinking, but like I say, no one knows what an ICB is or what systems are going to look like. And the ICB blueprint is it's a mess at the moment. The ICB blueprint's a mess, and it's going to be a mess probably for a couple of years. So it's kind of hard to know what it's going to look like. I think traditionally models of care are focused on the providers. So the trusts, the teams, the clinicians, the pool of specialist nurses. I think actually you need to think about the patient journey. We were chatting earlier about kind of rare diseases and chronic pain and that kind of like diagnostic odyssey that patients go on. And actually, if you put the patient at the center and enable that and don't have these individual silos, then I think it makes a lot more sense. The power of systems thinking and ICB level projects is, if someone's being referred from the GP and then they're kind of on a waiting list and then they see a community provider and then they see the acute provider and they bounce back to community, that, why should you have different tools for each? And actually a patient might have 5 simultaneous problems going on at the same time. And it's about making all that link up. So it's about interfacing that data and that patient experience. So I think, I'm not sure if Michelle's question is saying leaving members of the team, the kind of the healthcare provider team behind, as opposed to the patients, leaving individual patients behind. I think the things that unite us, this is a bit kind of post-Brexit, isn't it? But I think the things that unite us are actually more than things that divide us. I think the commonalities are much higher, and I think we're all aligned, and we all talk about providing patient-centered care. But I think actually it's not normally the case. I think.
Any more questions, Lawrie?
Yeah, so I suppose in product, it's always quite important to trace things. So if you've got a feature, you trace the traction that product gets, and you can actually use democratic kind of frameworks to do that. So impact versus effort. Do you find with kind of, and you sort of talked about the low budget pilot digital innovation, is there quite a lot of duplication of that across different trusts? And is there a way that there could be a sort of unified way of tracing the success of those pilots, and a democratic way of then saying, well, actually, there's evidence saying that this would be a really good solution and should be rolled out in a more scalable, sustainable way?
Yeah, so I think there's two things to the pilot thing. So one is I've got a product and I'm going to pilot it, in the BRI, and we're going to see if it works, and then we're going to try and upscale it. Or you can say, do you know what, we're going to do this as part of a big piece of work, and we're going to use a pilot to kind of break down the adoption barriers. And we're going to show people that it works by piloting something in a very specific, right-sided, big toe with this condition, and that's the only patients we're going to do. We're going to show it works, and then we're going to kind of build on that success. So I think there's kind of two different approaches. As far as the collecting the data, 100%, and that's what lots of people spend a lot of time doing, right? Because you need to work out what works, and if you look at the really big tech companies, they're constantly iterating, they're experimenting, they're doing kind of A/B comparisons all the time, trying to work out the reason why Instagram works so well is because they're constantly building an algorithm, and they're comparing, contrasting, working out what, whether you look at pictures of coffee machines or pictures of dogs, and how much time you spend looking at stuff. And, so yeah, that is done, that should be done. But I think you need the scale to do that properly, because otherwise your end number essentially is pretty low. So yeah.
Great, thanks.
Yeah. So I had a question. So you talked a lot about like roadblocks and things that are stopping the system from going, and a lot of it that you said has been like, oh yes, I recognize all of these problems. Have you noticed any changes to the positive to changing that system?
It depends. It varies massively from provider to provider. And sometimes you get champions. I think you need, along with the narratives, you need champions that at different levels. So champions, is nothing more than a bit of enthusiasm if they're at the wrong level, but they can be really powerful. And it's interesting when you hear stuff that you work with being talked about in a positive way, and you're like, oh, actually, that's way better marketing than anything our clever marketing team could ever possibly come up with. So those kind of narratives are really powerful. There is a change, and I think people are, and again, it's that push and pull. So for a long time, there's been like industry pushing stuff, and actually now people are going like, we need stuff, like there's a need. So for example, we've got a huge backlog of echoes, like cardiac echoes in our trust. Sorry, someone's ringing me, probably my mum. So cardiac echoes is a real problem. So we've got like basically staffing, logistics, and equipment challenges to it. And meanwhile, patients get more complex, so more and more patients need them, and have longer kind of tail of intervention and surveillance. So what can you do about that? Well, actually, there are some AI tools out there. They're not perfect, but it enables essentially a total novice to put a probe in a couple of places, hold it on until the kind of light goes green, and then the magical AI in the background processes the image and gives you kind of an idea of what the patient's heart is like. If you have that as a screening tool, you can automatically get rid of a whole bunch. Now that is an example of a kind of a pull from a need. And so something I'm doing with a couple of colleagues is we're looking and seeing what's out there and actually whether it makes sense from a kind of, we've got this problem. So I think the infrastructure within the organizations needs to be fit for purpose. I think honestly it's not a lot of the time. And I think it's also the kind of bandwidth and the headspace. So he's, again, very kind of unilateral lens, but Gloucestershire digital team have been fighting a fight with our digital PAC system for looking at x-rays for probably about 18 months now. And that has taken up so much time and bandwidth and energy. And honestly, I don't know what the problem is and I don't care. Okay. When I click an x-ray, I can see it and it works fine. But clearly there's massive problems in the back end. But it's meant that they've had to be very careful about what they commit to and what they roll out. So all these things are very difficult. I didn't talk about timelines as well. That's another real challenge. So if a trust is about to procure a new electronic patient record, so a kind of essentially an EPR is where all the patient's clinical documentation lives and all the kind of investigations are ordered and all the kind of blood tests are surfaced and all that kind of stuff. Really complicated. I mean, horrible pieces of software, but really complicated to implement. They are not going to want to embark on any kind of other transformation project because that is going to take everyone's bandwidth and resource and skills to manage that. So you need to kind of time it appropriately. And we've looked at kind of the ideal client profile in terms of some of our newer products and go like, don't even waste your time with trust A, B, and C because they're just at the wrong stage in their journey. Like, we might be about to renew. Well, there's no point in trying to like roll out something new if about to renew. What if they don't actually have the kind of the right kind of what if you don't have the right integrations with them yet? So, again, don't waste your time. That might be a conversation for in a year's time when actually it's a bit more of a mature relationship. What if the pilot didn't go that well actually because, all the people with the sore right knee didn't actually respond to the questionnaire because it got sent on a Sunday night rather than in daylight hours. All these things. So there's a lot of kind of nuance. But yeah, something that really frustrates me is people talk about health inequalities, which is very, very important. But there's kind of, if you live in an area where your local trust is essentially skint and doesn't have much money and isn't a big kind of hub of industry and research and has all this money coming in, then do you know what? They're probably going to be less digitally enabled as a trust. And so you're going to get a worse outcome. Whereas if you look at I'm going to use Moorfields as an example because they've got loads of money. Okay, they're a really ambitious trust. They're really, really exciting to work with. And they come to us with exciting ideas. But should the Moorfields patients get a better deal than the ones in, let's say, Doncaster? I'd say no. In fact, the patients in Doncaster probably need more of a leg up. But that's not how it works. So I think it's kind of wearing my kind of clinical hat. It's just the patients that serve me, so that's easy. Wearing my doctor hat, it's actually I see that come disparity much more, and I think that's where policy has to come in. And I think I don't know. I think incentivizing the right kind of stuff without making the incentives gameable is key.
We might have one very, very quick question if we've
If you've got one online,
yeah.
go ahead.
No, go into the topic online.
Okay, so my name's Phil. Thanks. I've worked in the private sector for my career. I was going to ask you a question. I think you started to answer it, but you're describing a problem that simply can't be solved. Or should we have another go? I mean, 20 years ago, Tony Blair, had a go at a very large, multi-billion-pound attempt to, automate the NHS, computerise the NHS, and there are some successes, but I think most people would say it failed. First time for a number of reasons. So it was very digitally led. It wasn't really problem centric, as you said. It's I just thought we were to change management and so on. Do you think we should have another go at a kind of real macro thing, do it completely differently, design the hell out of it for 3 or 4 years, roll it out in a very sensible way? Give thought to how people adapt to it, put an emphasis on patient adoption and so on.
Yes, that's a great question. I think I'm a massive optimist. Okay, and I think every quango that's being abolished and ripped up at the moment, and every ICB that's being merged and scrapped, and every NHS England employee who's out of a job, I'm really hopeful that'll enable a much more agile process to happen, and that it will happen. Will it? Probably not. But I'm hopeful, actually, because I think if you look at the COVID vaccine rollout, allegedly I wasn't there, but apparently they got all the people in the room that they needed. There was like hundreds and hundreds of people, and then they said this is ridiculous, and they got 12 people in the room who can actually make decisions, and that's how they managed to do it. Yeah. And so I think stripping back, and I'm acutely aware there's a lot of people who are, losing their jobs, who've got huge amounts of uncertainty, and who do an amazing job. And I'm not going to kind of discount the value that they add to the system, but I do wonder whether the duplicative nature of a lot of how things are at the moment, whether it's going to be a step change, whether spending 4 years designing the hell out of it is the right thing to do, because I think it's a little bit like Tetris, which is a massively dating me. Tetris was a game when the world was in black and white. When the screen's full, actually you can only kind of do stuff at the top of the screen. Yeah. But you've got this kind of backlog. You've got people who still need to be seen. So it's all very well doing all the fancy stuff with the new referrals, but what about the people who've been waiting like 2 years for their outpatient appointment? So I think you can't start from scratch. It's like building a new hospital. You can't just close one and then start building another. You kind of need to have 2 hospitals and then transfer across. And I think that's incredibly difficult to do. I think there's, I didn't talk about the federated data platform and Palantir. People have very strong feelings about it, but actually that could be leveraged in quite a powerful way. It costs 330 million. So that's quite a lot of money, and you'd hope to get quite a powerful return on that. I think no one knows what the future state will look like at the moment. I think that's incredibly difficult. I would love to see it kind of redesigned, but because of the way we have this weird kind of federal state in the UK in terms of trusts operating their own different little isolations. It's the 145 different procurement processes. And I think when things are centrally procured and centrally rolled out, actually it tends to be, not always, but it tends to be a little bit better, tends to be a little bit leaner. And I think Attend Anywhere is a good example. Stroke thrombectomy pathways, they work well. Major trauma networks, the kind of TARN stuff, works well because it's centrally led and it's kind of disseminated. It's not always the best way, but I think it can be. But I don't know how you would essentially build a almost digital twin, to use a phrase that's in vogue, for the NHS, and do it well. Yeah,
sounds
good one.
Yes, I think that's all we have time for this. We'll have a short break now, but thanks for being here.